you're on.
So, first off, thanks for being here this evening. This is a little bit of a clunky presentation this evening, just for the logistics of being in this new room. But the topic of my presentation tonight is oral microbiology, a hitchhiker's guide to the oral biofilm. Now, as just a little background. As you know, I'm a practicing dentist. This whole project started from Lisa Platt and I going to see and present Dr. Richie Shoemaker a Lifetime Achievement Award on behalf of AHEMA a little over a year ago. We ended up sitting next to him. He was on my left and Mary Ackerley was on my right. And we ended up hitting it off as far as talking about microbiology and Marcons and this and that, and he says, "Are you measuring it?" And I said, "Well, no." So I didn't even know what I was going to be measuring. So it started out with looking at Marcons, and then it added up to using the DNA connections, which I know you have up in Vita, and you may use it in your clinic and this and that. So what this was, and let me just kind of start to go through this. This material was only alluded to in my book that as soon it's out now, we're going to have a little kickoff party here next month. But it's alluded to in the book. I was in the process of accumulating the data to be able to even have this presentation tonight. So this is you see the cover of the book. In my model of healthcare that I look at now, I've started modeling dentistry in the center of a healthcare model. So that's the premise, and I've been using that premise for a number of years now. So you can see in this little slide, I put biological dentistry and wellness at the center with biomechanical, biofilms, different products, root canals, jawbone lesions, and what's that all about? Oh, incompatible dental materials. I'm sure there's probably something else that could be added to that, but in this model and for our presentation tonight, we're talking about biofilms, microbiology, and where are these critters from, the bacteria. Specifically, we're going to be looking at root canals and what are known as cavitations, also jawbone lesions, ischemic bone disease, there's a Ratner's cyst, there's another term, lots and lots of terms around that. And I started out looking only at, as a dentist, looking at teeth years ago. And the results of taking a tooth out and the problems with root canals and this and that. That started to expand about 9 years ago for me with the advent of, oops, okay. Now I'm on the teeth and the bone. Can you see that okay, Martha? Okay, so teeth and bones and root canals and jawbone lesions. What you're seeing here is a composite image from a 3D cone beam scan, CT scan of the head, and that can zip around the head and takes 14 seconds to capture, about 7 minutes to process, and then with the speed of a mouse flying across a sheet of paper, you can get a complete three-dimensional view of what's going on in the mouth. That fast. It's very, very quick. So this particular, pardon?
A lot of radiation too.
Well, it's less than a medical CT scan, but compared to not having the information, I suppose. Not here to argue the merits. Look at all the people on cell phones that are with them every day.
Well, everything adds up. That's the thing. So it boils down to what do we need, what don't we need, what can we avoid, you know? I mean, it's like if you take too many mammography, which somebody can argue, you're going to end up with breast cancer. So
right.
So it's same thing for
yes.
everything.
So for our this discussion tonight on the, and the oral, what is now being referred to in the higher centers of science, the oral microbiome. It's now been estimated that there are between 750 and 1,000 different life form species in and around the oral cavity, which includes the nose and the pharynx and the crevices between the teeth and the tissues. I was blown away, frankly, when I read that, as I prepared for this to get some good hard numbers. It's second only to the gut in diversity, and the gut being down here, it's just part of the same system, compared to, like I said, like the gut. So this is really a, not just bacterially rich, but there's protozoans, fungi, the bacteria, viruses, and this other one, archaea, which is another kind of a type of life form that I really don't know about very much. But it said, the research said there's only approximately 280 identified species that they've given names to. Now that's a pretty poor representation for our science to say there's 750 to 1,000 and only identifying 250 or 280. And when you think about it, the mouth and the oral cavity is a primary way of entry into the body. You know, and we're now calling the nose as part of the system. So it's a rich milieu of things which have to be filtered, which get lodged in things. So it's under a constant attack, a constant assault. So when you have these different bacteria that are coming in most normal circumstances, our body's able to deal with these things on a pretty regular basis, and we have, I like to say, ambulatory healthy people are walking around without having these problems. Now, as the physicians in this group, we see people that aren't ambulatory healthy, they're ambulatory unhealthy. So they're coming in and they're having all kinds of problems. And so back to Richie Shoemaker, knowing that we had this milieu, this mix of microbes and other things, and his focus was on biotoxin illness, chronic inflammatory response syndrome, CIRS, and MARCONS. MARCONS being multiple antibiotic resistant Staphylococcus coagulase negative aureus. That's a long term. I call it a MRSA lookalike or a MRSA cousin because it has some similar characteristics. So his question to me, knowing what I was doing with treating in the jawbone lesions, is where are MRSA bugs or the MRSA MARCONS coming from? You're swabbing it in the nose, plating it out on a traditional type Petri dish, and identifying it regularly in the nose of people that have had biotoxin illness, water damaged buildings, and the like. And so using the beg spray, for instance, is one of the treatments that they use, and cholestyramine to help keep down some of the inflammatory problems that people have. Why can't they eradicate it? Or if they can eradicate it, why does it always come back? So that was the premise of the look-see that we embarked upon. And so over the next year, I started then accumulating a trio of data points, looking at pathology, looking at the microbiology from the DNA connections. We're looking at the MARCONS from Microbiology DX out on the East Coast. So we have 3 different types of data points. And I'm going to show you here, and it's kind of small print. This is my one of my 3 spreadsheets that we've accumulating, all this data points that we have. And across the top are those microbes that we've had in my patient population. Okay, and then we've segregated it into the individual cavity lesions of suspicion in the jaw, wisdom teeth sites in particular, sites that have had an extraction previously but still had some pathology, or teeth that have had root canal treatments that are infected overtly or covertly that have been removed, and we sample those. And so I'm going to show you my data. So this is the micro data, the raw data. So as we get through this, you'll see some of that raw data coming down into better form. so now I haven't, if this will work, and it worked yesterday, I'm gonna show you a biofilm in action and how fast, it's not gonna work, darn it. It may not work on mine, if that may
Mine's
work
gonna
on
work.
yours. It's working? Okay. So you have a more souped up computer.
Kind of. I don't know, it's making lots of
So
seconds.
you're just gonna see a lot of squiggly things going by on the screen? Yes. So what it is, it's a plate that has a mix of bacteria and the like on it, and it's how fast the bioform is able to go from nothing to something of substance in really a matter of a minute or so, and how rapidly these biofilms can form within the body. So you can just watch that and let me know then when it's.
Interesting.
Last time you explained what biofilms are.
Pardon?
You explained what biofilms are last time.
Biofilms are just accumulations and aggregations of highly organized mixes of all those life forms that I mentioned in that earlier slide. So they seemingly come from nowhere and they congregate. And it's a very hierarchical microcosm. And out in the world we have microclimates. So on some of the mountainsides here you have different temperature gradations. Well, so too we have different gradations within these biofilms for oxygenation, pH, and the like, and it stratifies different bacterial forms or different, let's say, life forms within that strata. And it's very difficult to eradicate a biofilm with artificial means other than, they know scrubbing is one way to get it out. Like, so your drain pipes in your house, for instance, you have a clogged drain, you need to scrub that pipe, because I just had to take a pipe apart and you see this just filmy, gluey stuff in there. That's a biofilm. The plaque on your teeth every day that you clean off is a biofilm, and you scrub it, and it's, you can't just water pick it is not enough. You can't just take a toothpaste and run that around in your mouth. You can't take Listerine and run that around in your mouth. The best way is to scrub it off with a brush and wipe it off with dental floss. So I wanted to just talk, historically we've looked at biofilms, we've known about biofilms, especially we talk in dentistry about periodontal disease. Periodontal disease is an infection. It can be localized or it can be generalized, but it's typically been looked at, there's always bacteria associated with it. And the inside-out method of treating, which is helping somebody to boost their immune system, different than the outside-in treatment, which is going to the dentist every 3 months and getting your roots scraped and getting your gums scraped, things of that nature, is really not a superb treatment, because the bacteria hide, or the life forms hide. It's not just one life form type of thing. Now, the old Cook's postulates days, and there was one bacteria and kind of one treatment that was found, is now out the window, because we have such different set of bacteria, different life forms. We have people today now with all kinds of different problems in their bodies that are toxic. They have toxic overloads. I know your guys that are in environmental medicine, you see these things all the time. The body is having to deal with so much more now that all those old rules have morphed into some more advanced treatments that have to go on. And I've alluded to now here Lyme disease, which I started seeing probably 10 years ago. I started seeing people with Lyme disease, not to treat, but they would come to the office and they had a complete presentation of TMD problems. They had sore muscles, they had the sore joints, and they had the same kind of pain patterns. And so I would do my treatments for TMD and they wouldn't get better. So then I noticed, and we started correlating a few that I had, that as they got their Lyme disease under control, their TMD symptoms abated, and it wasn't a TMD problem at all in the classic sense of the word, but it's a look-alike problem. So this was a critical factor for me in understanding that pathophysiology is not just if things don't fit into that little box again. It just, that box just doesn't work anymore. Marcons I've just alluded to, courtesy of Richie Shoemaker. Now, I'm not doing in my office at all any MSH analysis to find out how somebody's doing with their melatonins, but that's one of the issues that comes to bear on that. I mentioned CIRS, and Lord knows what else may be going on with these people. I have no idea. Hi.
Hi, sorry.
Welcome.
Thank you.
Am I talking fast enough?
You're wonderful.
Okay, so this is my clinical research project. I have a total of 55 data points, which is a fairly good representation. So I have 15 patients, 55 data points, which is either a wisdom tooth area or some other area in the jaw or a root canal tooth. So I sampled every one of these independently. We're looking for Marcons bugs, we're doing the DNA analysis, and then we're looking at the pathology from under the microscope.
Nick, the DNA analysis that you're doing through DNA Connections, are they doing just Lyme and co-infections, or are they doing a bigger?
Well, actually, that's a whole separate test,
Okay.
the Lyme. So I'm doing the non-Lyme microbiology series,
Got it.
okay, so which is what that is now.
Okay.
Since you brought that up, I'll just say that I did one Lyme panel on one patient, because it's not an inexpensive test to do that. So I did out of my own pocket, because I was interested, would I be able to cultivate Lyme out of the blood flow that's in a cavitation site, and sure enough, I was able to cultivate Lyme out of the effluent blood from a surgical wound. So,
Wow.
Subjects with these, people don't come into the office without having a problem, obviously. So there's a skewed population that we're seeing. The people are sick when they're coming, and this now speaks to those. The primary conditions that people have are Lyme disease, chronic inflammatory response syndrome, and then the Marcons. So that's the basic population, the people, the family of illnesses that this subgroup of people have that I've done these treatments for. And so the purpose of this evening's presentation is only for the microbiology and not any of the pathology or really the Marcons. I'm not getting into that this evening other than to talk about it. So the next one are the results. Now I've taken that raw results of all these columns, and this made my eyes go buggy to see all this, but we were able to assemble this chart with the help of my staff. And so we had in site number 1, upper right wisdom tooth, there were 18 of these surgeries. So 18 site number 1s. No, excuse me, 18 people. Is that right? I'm getting confused. Site number 1. Oh, so we had 41 site number 1s out of mix, and 20 different bacterial species were identified. So that's kind of a lot. And there are almost all of them, I know I don't have the Marcons on here, but virtually all of them tested positive for Marcons in the maxilla, not the mandible, but the maxilla. The upper left, I had 44 sites with 19 species identified. Lower right, 17 sites, I had 15 species identified. No, lower left. Lower right then, 44 sites, 22 species identified. Upper right, root canals. Now, so these are just teeth that had root canals that we checked. So there were 34 teeth that were in this sample. And there were 22 different bacterial strands isolated out of a root canal tooth from this DNA analysis. Lower root canals, there were only 7. I had only 5 species in this mix. So then I had a couple that were not a wisdom tooth, not a root canal, but a spot within the jaw that used to be a tooth in it that I went into. So I had a non-root canal site on the upper one. I had one site had 1 bacterial species only. On the lower, there were 22 different sites that we did surgery on. There were 13 different species identified in that batch of people. So the take home on what this data, the simple take home, they're all infected. This group of people, all this stuff is infected. So I guess a question of wonderful conversational talk is, does it matter? If we have between 750 and 1,000 organisms as part of our human microflora anyway, are we just sampling kind of what's a normal mix or not? I don't know the answer to that, but it's a question that I think really has to have some serious conversation, because I can get excited about seeing all this mixed infections, but how detrimental is it to the host when they're suffering? I don't know the answer to that. I don't think this is a good thing, but this is what we're finding.
Well, they are presumably suffering because they came to see you, yes? I mean, they didn't just come for teeth cleaning.
Oh no, they're suffering in the whole world. You know, the whole body is suffering, struggling. So all root canal teeth treated were infected with multiple mixed strains. All third molar studies also had mixed infections within them. Conclusion, management of, so a big part of my practice for 30 years has been in chronic pain management of the upper quarter. So the management of chronic pain sufferers must include biofilm diseases as a look-see at this. Now, the backdrop of this is in a month I'm going to be talking to an international group of people that treat chronic facial pain. And this is new information for that group as far as the microbiological assay. About 10 years ago, I talked to the group about the cavitat with this problem as a way to measure, and now we've got some definitive information that I can share with them, so that's why I put that in there. This other concept is that the jawbones may act as a reservoir for the bacterial loads in other areas of the body. If we're trying to use, for instance, a beg spray on Marcons in the nose, then if that's going away, why is it repopulating? Where's it coming back from? So that's a big critical question. And from the body's defenses and the porosity of the bone can allow easy migration of the bone, of the bacteria from one to the other spot. So it's and you know, when you look at the sinus, the venous sinus and up in the posterior maxilla, that's a ripe area for bacteria to have access to that whole venous plexus that goes down into the heart sac pretty quickly. Now, this is out of my book. The chart that we have, this is part of the dental matrix chart that's from the book. And I know it's a little small, it was supposed to be on a bigger screen, but the idea is that the matrix shows a particular set of symptoms down the left side of the page that an individual might have. You can find the dot that's corresponding to your conditions, and then read up the column and see, is it periodontal disease related potentially, Lyme disease related potentially, or CIRS. This chart is available for free as a free download for people going on our website.
Cool.
So I'll just give it away.
And what is the website?
And the website is drnicholasmeyer.com. DRNICHOLAS Meyer, MEYER.com. So that's included in chapter 1. That's what the free download is.
Perfect.
This was the only chart I have ever seen like this. You know,
It's
incorporating decades of learning
Thank you.
in one easy-to-use chart. So I was very impressed with it.
So it's unique in the world. As far as I know, it doesn't exist elsewhere.
Well, we make it bigger when you download it.
Well, it's the size, in the book, it's the size of a, you know, each page is like this, and it's much easier to read. Here, unfortunately, it would have been better on the projector screen, not looking at a little laptop. Okay, I've alluded to this. So what are the, I changed slides.
Yes.
So Nancy, we're in a different room tonight that normally has a projector.
Mm-hmm.
So the jawbone lesions, cavitations, many of the bacterial strains that are found in the DNA connections, they're common to both of these kind of lesions. And they're obviously able to be left behind if a tooth is removed with a root canal or without a root canal. And in any infected tooth can transmit these bacteria. They can stay inside the jaw. They can, whether or not they're actually scraped out, they can come and repopulate that. I wanted to share with you the story of the individual actually that started this whole process going for me. It was a patient of mine that came through both Mary Ackerley and Richie Shoemaker, who was a physician from Tucson that had been in hospice. It was almost written off to go and check out and put his affairs in order. And he had significant electromagnetic frequency challenges. So he couldn't be around a computer, he couldn't be around a cell phone, he couldn't be around sun, he couldn't go out in the daylight very much. So he had a lot of that challenge going on. He had terrific irregular heartbeats on a regular basis, and he was able to get taken up to the office. And one of the things that I do in identification, and I'll show this a little later, is a diagnostic technique where I have a suspicion area. I will take a little anesthetic on a special little hollow port needle, put it into the bone and squirt a quarter to a half cc of